the topic of discussion that we are going to cover is we are going to cover gastric tumors, right? Under that gastric tumor, we'll be talking about gastric adenocarcinoma in detail. So what are the things that we'll be studying? The thing that we will be discussing is we'll be discussing about all these things, right? We'll be going through diagrams. We'll be going through the diagrams given in Robbins. Okay, and these are the things that we will be covering in this lecture. Okay, now without delay, let us move. Okay, the first thing that I would like to mention here is the most common benign tumor, right? Which is the most common benign tumor? The most common benign tumor of stomach, or we can say of stomach, is our leiomyoma, right? What is this leiomyoma? It is benign tumor of smooth muscle origin, right? And this is the most common benign tumor of stomach. Similarly, most common malignant tumor, and this is what we are going to study right now, and that is adenocarcinoma. The most common malignant tumor, or the most common gastric malignant tumor, is our gastric adenocarcinoma. And similarly, the most common mesenchymal tumor, it is our what? It is our GIST. And what is this GIST? It is gastrointestinal squamosal tumor. And the most common mesenchymal tumor is our gastrointestinal squamosal tumor. So now going in detail about what? Adenocarcinoma, right? Adenocarcinoma. What I've already mentioned, the adenocarcinoma is the most common malignant tumor, right, of our stomach. And here the adenocarcinoma, the first thing that we'll deal with is we'll talk about various risk factors of adenocarcinoma, and it is so important to talk about risk factor of adenocarcinoma. Okay, now without delay, I would like to take you toward what the first and foremost risk factor, and that is tobacco and alcohol. What this tobacco and alcohol will do is they will produce irritant, right? Irritant to our what? The lining of our GIT, and that may eventually lead to adenocarcinoma. Similarly, another risk factor is our nitrosamines. So these nitrosamines, these are so important, right? Why these are so important is that these are the most common cause of what? Adenocarcinoma in our stomach. This nitrosamine, the source of nitrosamine are our smoked food or the salty food, right? Smoked food or salty food, right? What they do is they will they are a resource of our nitrates, right? They are a resource of nitrate, and these nitrates, what they will do is they will be converted into nitrosamine or nitrites, and these nitrites are what? These are so prone to cause cancer. These are so prone to cause cancer. So with it, I would like to mention another thing right here, that is, right, if any substance that will enhance the conversion of nitrate into nitrites, then that is also a risk factor of what? Risk factor of adenocarcinoma. Such as if we will talk the food that are not preserved in refrigerator, right? The food that are not preserved in refrigerator, they can be partially decayed. If they are partially decayed, then what may happen is that there may be any bacteria, right, any microorganism that can convert these nitrates into nitrite, and that is why low socioeconomic condition, or the unrefrigerated or unhygienic condition, is also a risk factor for our adenocarcinoma. Now talking about the most important one, that is H. pylori. Now what is this H. pylori? It is so important that it is called as type 1 carcinogen for adenocarcinoma, this H. pylori, right? It is the most common cause, and it is considered as type 1 carcinogen for adenocarcinoma. Now moving further, there is our blood group A, right? The blood group A people are more prone to suffer from adenocarcinoma. Let us remember with one mnemonics, that is POGA, right? And what is this A? This is our blood group A. It is more prone to cause gastric cancer, and that is what? Adenocarcinoma. And similarly, talking about blood group O, right, these are more prone to cause what? Peptic ulcer. Okay. Now another thing is nutritional deficiency. Here we are talking about nutritional deficiency of micronutrients, right, such as what? Zinc, molybdenum, right, selenium. Okay, these are what? These are micronutrients. In this case also there can be what? There can be risks of adenocarcinoma. And another important thing that we have discussed earlier, that is Menetrier disease. Now what is this? This is our gastropathies, right? These are our gastropathies. We have discussed it earlier. So what happens in the case of Menetrier disease is that there is hypersecretion of our what? TNF alpha. What is this TNF alpha? These are transforming necrotic factor alpha, right? Now because of these, the increase in TNF alpha, what will happen is that there will be endothelial proliferation, right? Endothelial proliferation, and these endothelial proliferation will present as prominent gastric rugal folds, right? Prominent gastric rugal folds, as you can see right here. These are prominent gastric rugal folds, right? There will be foveolar hypertrophy also, right? And these will give rise to condition that we have discussed as worm bag appearance also, right? And these menintrace disease is also a risk factor for our adenocarcinoma, right? Now talking about what, since we are talking about what, we are talking about cancer, right? There may be certain genetic factor also, right? And talking about genetic factor, the thing that we need to know here is we need to know about some of the genetic factor that may cause what, that may cause our genetic factors. Now talking about genetic factors, the first thing that we need to know or understand is p53 gene, right? This p53 gene, what is this p53 gene? This p53 gene, it is our tumor suppressor gene, right? And if there will be mutation in p53 gene, right, there will be no suppression of tumor, and that will eventually lead to what, adenocarcinoma. Sometime in question there will be not mentioning of p53 gene, there will be mentioning of one condition, one syndrome, and that is Li-Fraumeni syndrome, right? There will be condition that will be mentioned, Li-Fraumeni syndrome, right? So if the person presents to you as Li-Fraumeni syndrome, at the time you will just figure out yourself that the person is suffering from what, low laser activity of p53 gene, because Li-Fraumeni syndrome is what, it is germline mutation of p53 gene, right? It is germline mutation of p53 gene. Okay, it is the same thing. Now moving toward another genetic factor, and that is our APC gene. APC gene is also a tumor suppressor gene, right? Because of underactivity of what, APC gene, right? Mutation in APC gene, or another gene is there, that another thing is there, that is our beta catenin, right? Catenin. And because of underactivity of APC gene and because of overactivity of beta catenin gene, what will happen is that there will be what, there will be activation of one pathway, and that is W and T pathway, right? And these W and T pathway, what it will cause is, it will cause proliferation of epithelial cells, right? Epithelial cells. And on excessive amount, what it will do is, it will give rise to what, adenocarcinoma. So it is also a risk factor for adenocarcinoma. Now moving further into another important gene, and that is CDH1 gene. Now what is this CDH1 gene? The CDH1 gene is the gene that is responsible for coding our E-cadherin, right? And this E-cadherin is a substance that will help in binding two cells together, right? It helps as a cell addition, right? If there will be defect in this CDH1 gene, right, if there will be defect in CDH1 gene, or there will be mutation in the CDH1 gene, what will happen is that there will be what, there will be loss of E-cadherins. As there will be loss of E-cadherins, the cells cannot adhere with each other so easily. Here there are two conditions that we need to keep in our mind, and the two conditions that we need to keep in our mind are, the CDH1 gene mutation is associated, or it is responsible for development of two type of tumor, and the two type of tumor are what, our gastric adenocarcinoma that we are studying right now. One is our gastric adenocarcinoma, and another thing is our lobular carcinoma of breast, lobular carcinoma of breast, right? So these are two important what, tumor that can result because of mutation in CDH1 gene, and in this both condition, what we will find will be, what we will find is, we'll find what mutation, what we will find is, we'll find the loss in activity of what, our E-cadherin, right? And this is why Why this is happening? This is happening because of what? Mutation in CDH1 gene. That's all. So this is important about CDH1 gene. Now moving further, now the thing that we need to study right here is we need to know about what? We need to also know about HNPCC syndrome, right? Now what is this HNPCC syndrome? It is also one of the risk factor for causing adenocarcinoma. It is also called LYNCH, Lynch syndrome. Lynch syndrome. Now this HNPCC syndrome, right? Okay, now it is the condition in which there will be defect in what? There will be defect in DNA repair, right? There will be defect in DNA repair, right? Therefore patient are having what? The patient are having microsatellite instability. The patient are suffering microsatellite instability, right? And this instability in microsatellite will therefore increase the high risk of causing cancer, right? The cancer, and that is our adenocarcinoma. So these are what? These are genetic factors that we need to know. We need to remember p53 genes, APC genes, beta catenin. We need to know about CDH1 gene, E-cadherins, and we need to what? We need to know about HNPC syndrome or Lynch syndrome, right? Okay, now as we mentioned already about what we already mentioned about different risk factor, right? Different risk factor. Now what we'll do is we will move toward what? Okay, we will move toward our what? Location. Now talking about location, the main site in which adenocarcinoma will affect is it will affect the antrum region, right? Antrum region. And if you just go to our other thing, then there will be what? The involvement of laser curvature, right? Similarly, okay, there will be the involvement of laser curvature, there will be the involvement of greater curvature, but more prone is to laser curvature, right? Okay, there is one important clinical correlation right here. If there is no mentioning of any history, right, and it is simply asking about what? It is simply asking about the location of adenocarcinoma of stomach, then we will just mention what? Antrum, right? Lesser curvature and greater curvature, will just go according to priority. But if there will be what? There will be history of pernicious anemia, right? If there is question in which there is mentioning of history of pernicious anemia, then this adenocarcinoma will be mainly involved in the region of body and fundus. Okay, what I'm saying is if there will be involvement of what? Pernicious anemia, then there will be what? There will be effect in our fundus, right, and body, right? Okay, this is one important thing that we need to keep in our mind. Okay, now moving further, what we'll deal with right now is we'll be talking about what? Clinical manifestation. Okay, the clinical feature manifestation that we will see is there will be satiety, right? Now what is this satiety? It is the feeling of fullness, right? Fullness. Okay, now I would like to take you toward one thing, and the thing is, okay, right here, okay, right here, this is our stomach. What is this? This is our stomach, right? This is our stomach. If there are if there are cancer, right, if there are cancer or tumor in our stomach region, then obviously there will be less space. What? There will be less space in our stomach for our food. So what will happen is that there will be always what will happen is that we will always have a feeling that something is there in our stomach, or we will always have a feeling of fullness, right? We will not feel hungry, right? There will be loss of appetite, right? And there is one important term written right here, that is postprandial happiness. Now what is this postprandial happiness? Is that when we will have something, right, when we will have something in little quantity, right, just having little quantity of something, at that time you will have a feeling of fullness, right? You will have a feeling of happiness in your stomach, and that is what we call what? Postprandial happiness, right? And it is the earliest manifestation that we'll face. Now because of this, what will happen? We'll not like to have a lot of food material, and there will be obviously weight loss, right? And the weight loss is the most common clinical feature. Okay, and this will be also presented as abdominal pain, right? Abdominal pain. Now here I would like to mention another thing, and that is this adenocarcinoma can be also associated with paraneoplastic syndrome. Okay, the paraneoplastic syndrome, in which, right, there will be hyperpigmentation of skin mainly in the region of axilla, and that is what we call acanthosis, right, acanthosis nigricans, acanthosis nigricans, and that is what we call acanthosis nigricans. And similarly, there can be what, there can be many pigments in found in our skin, right. There will be many pigmented what, skin lesions, and that is what we called what, that is what we called laser, right, laser trilect sign, that is what we call laser trilect sign, and it is also what, it is also a manifestation, clinical manifestation of our adenocarcinoma. And similarly, what we will find is, we will also find migratory thrombophlebitis. What we will find is, we will find migratory thrombophlebitis. Now, what is this migratory thrombophlebitis? It is the condition in which there will be development of thrombus, right. There will be development of thrombus, right, thrombus in small vessel, in small vessels, right, thrombus in small vessel. So the patient right, the patient will just present with MAHA. Now, what is this MAHA? It is microangiopathic hemolytic anemia. So I mentioned about 3 conditions right here, right. Now, here talking about the clinical manifestation of what, clinical feature of our adenocarcinoma of stomach, right. It can be presented with paraneoplastic syndrome. The first one is hyperpigmentation of skin in the region of axilla, and that is what we call what, acanthosis nigricans. Similarly, right, there will be many what, many pigmented skin lesion, and that is what we call what, laser trilect sign. And similarly, what we will find is, we will find what, migratory thrombophlebitis, right, phlebitis. Now, what is this migratory thrombophlebitis? It is what, it is thrombus in small vessel, and that is what, that can be presented with also what, MAHA, and that is microangiopathic hemolytic anemia, right. Okay, now this was about what, this was about clinical feature of our what, clinical feature of the patient suffering from what, adenocarcinoma. Now, since this is what, since this is our malignant tumor, since we are talking about malignant tumor, obviously this malignant tumor has what, has a feature of metastasis or spreading, right. And the most important, right, the spreading of these adenocarcinoma takes place with the help of what, hematogenous origin, right, hematogenous route or hematogenous spread. Now here, right, now this hematogenous spread will cause mainly the involvement of our liver, right. It is the most common involvement in spreading of adenocarcinoma. Similarly, there are involvement of lungs also, right. Now, I would like to go to our important points, right, in which we have different names, and that is lymphatic spread, right. Before we were talking about what, hematogenous spread, now we will be dealing with lymphatic spread. Now, here there will be involvement of what, involvement of obviously lymph node, right. Okay, now as there will be the involvement of lymph node, there will be the involvement of what, the ovaries, right, ovaries. So we will go toward ovary just later on. Now, let us talk about what, the lymph node involvement. So what is this? This is our stomach. As you can see, this is our stomach. As you can see, the adenocarcinoma of stomach will what, the initially what will happen is, as here we have shown, right, through lymphatic spread, right, it will reach the region right here. Now, what is this region? What is this right here? It is left sided what, supraclavicular lymph node, right, supraclavicular lymph node. Now, because of what, because of passing of what, because of passing of tumor cells, right, tumor cells within what, within left sided supraclavicular lymph node, there will be enlargement in this lymph node, right. As this lymph node will be enlarged, it is called Virchow's lymph node, Virchow lymph node, Virchow lymph node. So okay, now if you just remember the word Virchow, is that we have studied this Virchow in various things, such as we have studied this Virchow in the case of what, Virchow's stride, right, Virchow's stride, where we studied this Virchow stride in the case of thrombus formation. Similarly, we studied about this thing in Virchow's what, Robin's space, right. Now, Virchow Robin's space, it is found in what, it is found in brain. And similarly, we studied about this Virchow in Virchow's cell. Now, these Virchow cells, it are found in what, these are found in the infection of what, these are found in the infection of Microbacterium leprae, right. Okay, Okay, we are talking about what? We are talking about Virchow's lymph node, right? Why this Virchow's lymph node happened? It happened because of what? Because of what? Spread of tumor into what? Lymph node. Which lymph node? Right? Which lymph node? Our left sided supraclavicular lymph node, right? Okay, now moving little down, right? What we have is, we have what? Left sided axillary lymph node. So if there will be what? There will be spread of tumor in this left sided axillary lymph node, then it will be called iris lymph node. And similarly what we have is, we have another, and that is around umbilical region, and that is what? That is our para-umbilical areas, right? Involvement of what? Subcutaneous tissues around umbilical, right? Now this is what? Para-umbilical area, and this is called Sister Mary Joseph lymph node. So why Sister Mary Joseph lymph node? Because there was sister, right, who observed the para-umbilical areas filled with what? Filled with the tumor cells, right? Tumor cells in the case of gastric adenocarcinoma. And since she observed this for the first time, and it is, the name is kept on her, and that is Sister Mary Joseph lymph node, right? Okay, now there is one last, and that is what? That is our POD involvement. Now what is this POD? This is pouch of Douglas, right? What is this pouch of Douglas? This is what? Retroperitoneal fold, right? Retroperitoneal fold. Since it is retroperitoneal fold or pouch of Douglas involvement, right? And it is what? It is called what? It is called Blummer's self. It is called Blummer's self. Okay. Now this POD, pouch of Douglas, it is clinically what? It is clinically examined, right? This pouch of Douglas, it is clinically examined, right? As it is clinically examined during pre-rectal, or in the case of female in pre-vaginal, per-rectal, or in the case of female per-vaginal examination, right? During examination there would be what? Irregularity, right? And that irregularity is what we call Blummer's self, right? That is what we call Blummer's cells. So okay, the same thing is mentioned right here. As you can see, the left supraclavicular lymph node, right? If there will be effect in left supraclavicular lymph node, that will be called Virchow's node. If there will be left axillary lymph node involvement, that is iris node. If there will be peri-umbilical nodules, that is Sister Mary Joseph nodule, right? If there will be involvement of pouch of Douglas, that will be what? Blummer's self, right? Blummer's self. Now we'll move to our what? We'll move to our ovary. Now here in the case of ovary, as we said, that we'll be discussing it later, right? What will happen in the case of ovary is that, okay, as you can see, right, the ovary will have what? Bilateral involvement, right? Okay, bilateral involvement. The ovary size of ovary will be what? Increased. The size of ovary will be increased, right? Now here the size is increased because of what? Because of metastatic, right? Metastasis, right? And this metastasis enlargement of ovary is called what? Metastatic enlargement of ovary is called our Kronkenberg tumor. What it is called? It is called Kronkenberg tumor, right? This Kronkenberg tumor, it is not just found in our adenocarcinoma of stomach, it is also found in other different cases such as breast cancer, right, colon cancer, but the most commonly it is found in the case of our stomach cancer, that is what is adenocarcinoma. So this Kronkenberg tumor is so important. Okay, now now moving further, what another thing that we would like to deal now is, now we will be moving toward what? We will be moving toward diagnosis. Now how we are going to diagnose, right? In order to diagnose it, what we will do is, we will just observe it with our one eyes, right? Now we'll observe it with our one eyes. Now after observing, right, observation with our one eyes is done with the help of endoscopy. Now in endoscopy we'll find it is an ulcer, and after endoscopy what we'll do is, we'll just take tissue from that area and we'll observe on a microscope, and that is what the biopsy. We'll do biopsy, and this is the what? Investigation of choice, right, in the case of diagnosis. So we're doing biopsy, right? We're doing biopsy or we're doing endoscopy, right? what we'll do is we'll doing biopsy and endoscopy, we can classify our this adenocarcinoma in various important classes, okay, on important basis. The first one is we can just classify it as morphological appearance, how it is seen, right? And another criteria is that we can classify it on the basis of depth of invasion. And another classification is the important classification, that is histological classification, and that is the histological classification is also called Lorentz classification. Now talking about morphological appearance classification, the thing that we need to study here is that we will just find out whether the cancer is it has flat growth, or it is ulcerative lesion, or it is it is internal lesion, or these things, right? We'll just in this morphological appearance we'll just find out these things, right? And talking about the depth of invasion, right, on the depth of the invasion, what we'll just find out is we'll find out how our these cancer are affecting our different histological structures, such as in the depth of invasion, what we'll find that there will be a mucosa and some mucosal involvement in the case of early phase of our cancer, but in the late phase what we have the involvement of muscle and serosa, right? And this is according to our according to depth of invasion, right? Now here the thing is, the early one that has superficial involvement, that is mucosa and some mucosa, these have better prognosis, but the late one that is a bit deeper and that is involving muscle and serosa, that has poor prognosis, right? Okay, now talking about the most important one, histological classification or Lorentz classification, right? Histological or Lorentz classification, we have two types. One is intestinal and another is diffuse type, right? Intestinal and diffuse type. Okay, I'd like to take you toward this table, right? Okay, now talking about intestinal and diffuse type, let us talk about intestinal type. Now it is called intestinal type because here the cancer cell, the tumor cell will have, right, the tumor cell will have the appearance that are similar to intestinal glands, right? Intestinal glands. Now okay, this is the structure of gland, right? Now here the tumor cells are presented gland-like appearance, right? In gland-like appearance, you can see right here. Now this will happen how this is like a gland-like appearance. So as they are presented in gland-like appearance, they are localized, right? They are not spreading here and there, they are not diffuse, they are localized. So these are localized cancer, and since they are having gland-like appearance, they are called gland-like tumor also. Now here what will happen is that there will be APC mutation. That means there will be presence of APC mutation. There will be lesser activity of APC gene. Now what is this APC gene? It is tumor suppression gene, right? And as there will be suppression of tumor suppressor gene, obviously there will be the condition of cancer. Okay, now as they are localized in one place, right, there will be the better prognosis, right? We can just find the exact location where the cancer is taking place, or where these tumor cells are present. So it is having better prognosis. Now moving further, the next thing is, now let us move toward diffuse type. Now before getting into diffuse type, I would like to mention that okay now here the cancer can be in form of ulcerative lesion or exophatic lesion, right? It can be in any of the form, and it is mainly occurred in elderly patient, mainly, especially in male, right? Now talking about diffuse type, here in intestinal type, what we are saying, these are localized, right? They were just having gland-like appearance, they were localized in one place. But here in the case of diffuse type, what is going on here is they are not adhered with one another, right? And if you remember, previously I have mentioned that there is one protein, right, that will help in adherence, right? That will help in adherence of two cells, so that they will be together, they will be together, right? And what was that protein? That was E-cadherins. E cadherin, right? And this E cadherin was produced by what? This E cadherin was coded by our CDH1 gene, right? So what will happen in this case in diffuse type is that there will be what? There will be mutation in CDH1 gene, because of which this cannot code for what? This cannot code for our E cadherin, right? And as there will be the loss of E cadherin, the two cells are not what? Adhered with one another, and they will just remain in diffuse manner. So this is about what? This is about diffuse type, right? So here the tumor cell are diffused, right? They are scattered here and there. Since they are scattered here and there, they are not localized, right? And we cannot find the exact location of tumor, so these have what? Poor prognosis, right? These are poor prognosis. Now talking about another thing, okay, let us move toward how they will be seen, right? Okay, now there will be signet ring appearance in the case of diffuse type. Now how there will be the signet ring appearance, I would like to take you toward that. This is our tumor cell, right? Tumor cell. Now this is our nucleus, right? And inside tumor cell, what we'll find is mucinous vacuole, right? Mucinous vacuole. And this mucinous vacuole in our what? In our this tumor cell will push our nucleus to our periphery. As it will push our nucleus to periphery, these structure will be seen like what? Signet ring appearance. So the important another important point what we discussed right now is we talked about what? Signet ring appearance, right? Signet ring appearance, how it will, there will be signet ring appearance, there will be signet ring appearance because of mucinous vacuole, presence of mucinous vacuole, right? Okay, now here another important thing is that since we said that this diffuse type consists of what? Diffused tumor cells, right? They can what? They can infiltrate anywhere, right? They can go anywhere. So what will happen is that there is high chance that this diffused cell, they will just go and infiltrate into wall of what? Intestine, right? Wall of GIT, right? Because of infiltration into wall of GIT, what will happen is that, right? Okay, as you can see, this is our stomach, and you can see the wall of stomach, it is so thick. Why it is so thick? Because this diffuse type, in this diffuse type, the tumor cells are going and infiltrating into what? Into the wall of stomach. As there will be high infiltration into the wall of stomach, what will happen is that these wall will be so thick. As they will be so thick, right, there will be what? There will be leather bottle appearance, right? Thick, it means thick. Okay, there will be leather bottle appearance, and that is what we call linitis plastica, right? So this linitis plastica, which is leather bottle appearance, is also so important, right? And here we can see that there will be growth of fibrous or connective tissue also, and that is what we call desmoplasia. So this is about what? This is about diffuse type. As you can see right here, okay, let us move toward what? Intestinal and diffuse type. As you can see right here, in intestinal type we say that they are presented as a gland, right? As a gland localized in one place. As you can see right here, this is what? This is intestinal type. And talking about diffuse type, what you said that these are what? The signet ring in shape, right? You can see right here, these are signet ring in shape, right? As you can see nucleus, right? These are signet ring like structure. Okay, now moving further, right? Yes, we talked about linitic plastica. Yes, we said that these are leather bottle appearance, right? Now why this will happen is because of diffusely infiltrate that intergastric wall without forming an intraluminal mass, right? Without forming an intraluminal mass, where this will happen. Now in this condition, what will happen is the wall of stomach is thickened up to 2 to 3 centimeter, right? As you can see, the wall of stomach is thickened up to 2 to 3 centimeter. Leathery and elastic consistency is seen and develops due to desmoplasia. Now what is this desmoplasia? Extreme fibrosis in a tumor, right? Yes, we have discussed right here desmoplasia. Okay, now okay, we talked about what? We talked about intestinal and diffuse type. Now let us move toward this type. Now this chart. Yes, intestinal and diffuse, right? This intestinal is bulky polyploidal lesion, right? They appear as a gland, right? Bulky polyploidal lesion. But here in diffuse, what is this? Infiltrative lesion, right? They are diffuse in nature. Talking about pathogenesis of intestinal one, right? It is mutation in WNT pathway, right? Why WNT pathway? Because we mentioned that, right? There was a loss in APC gene, right? APC gene, and this APC gene, what is this? This is what? This is our tumor suppression gene. as our p53 gene. Now as there will be loss in what tumor secretion gene, suppressor gene, what will happen, this WNT pathway will start, there will be mutation in WNT pathway. As a result there will be what, epithelial proliferation, right? Now similarly, talking about pathogenesis of diffuse type, what we have is we have CDH1 gene mutation. Now what is this CDH1 gene mutation doing? It is causing loss of E-cadherins, right? And these E-cadherins, now it will stop addition of two cells. As a result there will be what, diffusion of what, our tumor cells. Now okay, now H&E stain shows what, glands lined by malignant cells, yes, that's sure, and it has a better prognosis because they are localized. Here H&E stain shows what, mucin secretion and signet ring cells, yes, we know that, right? And here the prognosis is poor. Okay, we went through what, we went through the difference between what, intestinal and diffuse classification. Now here as you can see, what is this thing? Okay, here this is the diagram from our Robbins, and here what we'll find is, we'll find the here this both are what, gastric adenocarcinoma. The first A1 is intestinal type. This is our intestinal type consisting of elevated mass with heaped up border and central ulceration. You can see central ulceration and you can see heaped up borders, right? Heaped up borders. This is what, this is morphology. And okay, now another is type B, right? Type B is what, infiltrative type or diffuse type, right? And you can see linitis plastica, right? Linitis plastica means thickening of wall of what, stomach, right? Okay, gastric cancer, the gastric wall is markedly thickened and rugal fold are particularly lost, but there is no dominant mass. Yes, the wall are so thickened, right? And as you can see, rugal fold are partially lost. You can see there is no proper rugal fold right here. So now what is this diagram, histological diagram? It is what, it is showing you what, signet ring appearance. As you can see, right, as you can see right here, these are what, these are signet ring appearance, right? You can see right here signet ring appearance. Now this signet ring appearance, it is the feature of what, it is the feature of our diffuse type of our what, diffuse type of adenocarcinoma. So as you can see right in this diagram also, this is intestinal type, this is diffuse type. In intestinal type you can see localized, right, gastric gland like appearance you can see here, but in the case of diffuse type, as you can see, right, as you can see, what will happen, there will be the appearance of what, signet ring like appearance. Okay, this was about what, this was about our gastric tumor, right, and detail about gastric adenocarcinoma. Hope it's clear to you. Thank you and have a great time.